Welcome back to the deep dive. Today, we're really immersing ourselves in a huge shift. The digital transformation happening in one of the most demanding fields out there, surgical practice and education.
Yeah, it's been dramatic for, what, 2 decades now? Technology hasn't just been giving surgeons new gadgets, it's been a genuinely disruptive force.
Right. Forcing the whole system to rethink how it trains its experts.
And it created this fundamental conflict, really. The question became, how do you maintain these incredibly high, rigorous standards for surgical training, traditionally built on time, volume, mentorship, when you're suddenly hit with these major constraints? First, those hard limits, like resident work hour restrictions. They just cut down on vital time in the OR.
A huge change.
And second, at the same time, surgical techniques themselves were evolving so rapidly. Think about the shift to minimally invasive stuff like laparoscopy.
So the old way, the sort of see one, do one, teach one model that just couldn't keep up.
Exactly. It was squeezed by both less time and more complex skills to learn. The whole pedagogical model was fundamentally strained.
So the system needed a redesign. And our guide for understanding this, this technical revolution, is a key chapter from SCHWARTZ's Principles of Surgery. It really maps out how the internet and social media didn't just, plug a hole.
No, they actively revolutionize things. How trainees learn, how established surgeons stay current. It changed the whole landscape for acquiring knowledge and skills.
Absolutely. So our mission today is to really master this material, like the professionals who use it every day. We need to unpack the advantages, look hard at the evidence. Is it actually effective?
Yeah, that's crucial.
Pinpoint the specific applications, from structured learning to, things like crowdsourcing. And maybe most importantly, get a handle on the ethical side, the pitfalls that come with this digital world.
There are definitely pitfalls. It's not all smooth sailing.
And just to set the scene, think about this statistic from the source. Nearly 9 out of 10 American adults use the internet now.
Right. It's not optional anymore. It's integral.
So its integration into a field like surgery, it was bound to happen.
Okay, so let's start with those disruptive forces. The source really zeroes in on those work hour restrictions as a primary driver. Before those limits, residency was heavily based on just time, sheer volume of time spent in the hospital.
Which meant more exposure to cases, more repetition, more time to just absorb everything.
Exactly. And the moment you cap that, often at 80 hours a week, you create this immediate deficit in exposure. Then that second force kicks in, the rise of specialized techniques. Laparoscopy is the big example.
And those skills are just different, aren't they? Not like open surgery.
Completely different. You're dealing with altered hand-eye coordination, depth perception issues, manipulating instruments remotely. It's counterintuitive if you learned open surgery. The old apprenticeship model really struggled to teach these complex psychomotor skills efficiently within those new time limits.
So the solution had to come from technology.
Pretty much. The enabling technologies were the internet and all the web-based applications that followed. They allowed educators to essentially redesign the system outside the physical confines of the hospital walls.
And that brought about, a revolution in education in, 3 key ways?
I'd say 3 main ones. First, just the expanded reach. Suddenly, high-quality educational content, lectures, videos, expert talks wasn't locked up in major academic centers anymore.
It could go global.
Instantly. Second, and this is massive for residents with those crazy schedules, the internet enabled asynchronous learning.
Meaning you don't all have to be in the same place at the same time?
Exactly. Students and instructors aren't tied to the same schedule. A resident can tackle a required module at, say, 2 a.m. after being on call all night. A surgeon in a rural area can access the latest research immediately. That flexibility is a direct answer to the time crunch.
Okay, reach and asynchronicity. What's the third?
Multimedia. We move beyond just textbooks. Now you have interactive lessons, high-def surgical videos, quizzes that engage you. It's a richer sensory input, a more interactive way to learn than the old classroom model could ever offer.
Right. And this whole shift paved the way for the next big player, social media.
Yeah, which is a really broad term, isn't it? We're talking about all these computer-mediated platforms. Basically, tools designed for creating and sharing information, ideas, content.
But importantly for this conversation, we need to focus on its function, right? We think Facebook, Twitter, Instagram, personal stuff. But here,
the core function is about facilitating communication and interaction within professional networks, virtual networks. It turns passive learning into something much more active. People become contributors, network builders.
So surgeons, researchers, trainees, they can use these platforms for ongoing professional development, sharing tough cases maybe, getting research out faster.
Absolutely. Sharing challenges, disseminating practice-changing findings at speeds that print journals just can't match. It's dynamic, rapid-fire interaction, which is, interestingly, quite different from the more structured web-based learning we should probably talk about next.
Okay, yeah, let's move to that more formalized side. Web-based education. This sounds like the structural backbone. We're talking comprehensive systems here.
Exactly. Formal lectures, sure, but also live webinars, sophisticated virtual reality simulators, tools for objective assessment, even interactive telementoring and coaching. It's a whole package.
And developing entire web-based curricula seems critical. Systems that link out to other resources.
Right. They often link directly to essential online stuff.
Yeah.
Peer-reviewed journal articles, highly detailed interactive anatomy modules, and, crucially for surgeons, curated videos of actual operations showing key steps.
So it's like a one-stop shop, a centralized, organized library of everything you need.
Pretty much. And the advantages, well, they tie right back to overcoming those initial problems we talked about. For trainees, it's unlimited access, 24/7, regardless of their duty hours. They can use interactive tools, replay tricky anatomy sections or procedure videos over and over.
And for surgeons already in practice, what's the draw for them?
For them, it shifts more towards maintaining competence and staying current. They get access to forums where they can ask about challenging cases, get rapid updates on new technologies or research, and do those formalized self-assessment quizzes for, say, continuing medical education credit.
But like you said, it's not perfect. What are the downsides? The source mentions a couple.
Two main ones. First, the cost. Significant upfront cost to develop, maintain, and constantly update these high-quality, high-fidelity materials, especially the simulation software. That's a big investment.
And the second?
Technical glitches. Plain and simple. Server outages, software that's not compatible, poor internet. Any of that can totally derail a learning session. It really highlights how dependent the whole system is on solid digital infrastructure.
Okay, that leads us straight to the big question, doesn't it? Does all this digital stuff actually make surgical education better? Let's unpack the evidence, because you said it's nuanced.
It really is. The consensus among experts is clear. You have to see web-based learning as one tool among many. It's part of a blend. We can't just assume it's superior because it's techie.
The systematic reviews really show this, right? Let's start with those Cook studies from 2008 and 2010. They looked broadly across healthcare.
Yeah, across the board.
Yeah.
And the first finding was, well, pretty basic. Internet-based learning is definitely better than no intervention at all.
Okay, sets a baseline. Low bar, maybe, but important.
But here's the kicker, the part that often surprises people. They found its overall effectiveness was statistically similar to traditional methods, lectures, textbooks. It wasn't demonstrably better at making people retain knowledge or acquire skills.
Hold on. If the outcome is just similar, why bother with the revolution? Why is it so necessary?
That's the key insight. The value isn't necessarily superior learning outcomes per se, it's superior scale and flexibility. Because it's asynchronous and global, you can reach thousands of trainees efficiently, anywhere in the world, without needing them all in one room at one time. That scalability is the real power, addressing those initial constraints.
Okay, that makes sense. It's about delivery efficiency.
And Cook's later review, the 2010 one, gave us the roadmap for how to make it effective. It wasn't just about putting stuff online. Effectiveness came down to specific design elements, real interactivity, practice exercises, repetition, and crucially, feedback. Immediate constructive feedback.
So just digitizing a lecture probably won't cut it.
Unlikely to move the needle much, no. Then, when researchers looked specifically at surgery, that was the Jayakumar review in 2015.
Right. They reported a positive effect from e-learning in surgery, but there was a big but.
A huge caveat, yeah.
Yeah.
They pointed out that most of the studies they looked at didn't have a proper control group.
Meaning you can't definitively say it was better than traditional methods because there was no comparison group.
Exactly. So the claims of superiority are premature. What the literature really needs now is more rigorous study. We need randomized controlled trials to isolate which web-based elements truly drive the best outcomes. And importantly, these things need to be developed with adult learning theories in mind, problem-based learning, self-directed assessment, that kind of thing.
Okay, let's talk about a concrete example. The Surgical Council on Resident Education score, that's a big one, right?
Huge, a massive undertaking, started back in 2006. It's a widely used national curriculum, all delivered through this comprehensive online portal. backed by major players like the American Board of Surgery, the American College of Surgeons.
And it's designed to cover the whole residency, 5 years.
5 years of general surgery content.
Mhm.
And the genius of it is how it's structured. It maps directly onto that required educational framework, the 6 core competencies every graduating resident needs.
Let's list those for clarity. Patient care.
Medical knowledge, professionalism, communication skills, practice-based learning and improvement, and systems-based practice. SCORE aligns content to all of those.
So the portal gives residents text, videos, quizzes, all tailored to where they are in their training.
Precisely. It's really the gold standard for centralized surgical knowledge delivery online.
And there seems to be a but with a lot of this. There's still an evidence gap, isn't there? Even with something as established as SCORE.
There is, and it's something anyone aiming for mastery needs to grapple with. While you see some positive signs, like residency programs using SCORE tend to do better on standardized exams, the source is clear. No studies have definitively shown that using SCORE improves a resident's actual knowledge, their technical skills, or, the bottom line, their overall clinical performance.
Wow, why is that proof so hard to get? It seems like such a standardized system.
It comes down to measurement challenges, really, and ethics. How do you ethically run a trial where you withhold SCORE from a control group of residents? You just can't. Plus, measuring long-term clinical competence, actual patient outcomes. That's incredibly complex. It takes years of follow-up, and there's so many other factors involved that it's hard to isolate the effect of the curriculum itself. So the profession accepts SCORE because it standardizes knowledge delivery, but proving it makes a better surgeon in the OR, that remains really tough methodologically.
Okay, let's shift from knowledge to skills. This seems like where web-based tools and digital assessment might really shine. Simulation, video assessment, coaching.
Absolutely. This is where we move beyond just knowing stuff to actually doing stuff well. Psychomotor skills.
The Birkmeyer study from 2013 sounds foundational here. They looked at videos of bariatric surgery.
Yeah, blinded reviewers watched videos and rated the technical skills. Then they correlated those skill ratings directly with patient outcomes.
And the results were striking.
Astonishingly strong correlation. Surgeons rated as having better technical skills had significantly lower rates of major complications, fewer reoperations, fewer readmissions, fewer ER visits. The message couldn't be clearer. Technical skill, objectively measured, directly impacts patient safety and quality.
Which is where simulation comes in. Virtual reality, web-based simulators. They're not just for practice, they're assessment tools.
Exactly. They provide objective metrics you can't easily get in a live OR. Things like efficiency of motion, how smooth are your movements, instrument angles, time to complete a task. And they give real-time quantitative feedback.
We need to understand the validity here.
Yeah.
The source mentions 2 types, construct and criterion validity.
Right. Construct validity basically means, does the simulator actually measure what it's supposed to measure surgical skill? Does it reliably tell a novice apart from an expert? An expert should have much more efficient movements, less wasted motion, and the simulator needs to pick that up.
Okay, it measures the right thing. What about criterion validity?
That's the practical test. Do the simulator scores actually predict performance in the real world, in the operating room? And studies show they do. If you train on a simulator and improve your metrics time, efficiency that correlates with faster operative times and better subjective ratings of your performance in a live surgery, the simulator score is a decent predictor.
And this isn't just for trainees. It's being used for practicing surgeons, too.
Yeah.
Video-based coaching.
Yes, this is about lifelong learning, continuous improvement even for experts. The idea is the surgeon reviews a video of their own operation afterwards.
Outside the pressure of the OR.
Exactly.
Yeah.
Low stakes. Allows for specific, individualized feedback on areas for improvement. And this capability extends even further with telementoring.
Guiding surgeons remotely, like across the globe.
Potentially, yes. An expert in one city guiding a surgeon performing a complex procedure somewhere else entirely using real-time video. The tech is there.
But the source notes a big barrier to widespread use, especially among established surgeons. And it's not the tech.
No, it's behavioral. It requires a major culture shift. Surgeons are highly trained, autonomous professionals. Getting them to willingly accept critique and coaching on their technique after they're established experts, that challenges the traditional idea of individual mastery.
So it needs more than just cameras and software.
It needs resources, dedicated time for expert coaches, a payment structure that supports it, and fundamentally a shift in mindset towards embracing continuous, externally guided improvement.
Okay, so we've covered the structured side. Now let's pivot to the more dynamic, maybe less predictable world of social media and surgery. Networking, education. It sounds much more interactive.
Definitely more interactive, multi-directional. In surgery, the big platforms mentioned are Facebook, Twitter, and YouTube. Facebook seems generally the most popular for networking. It lets you share info, photos, videos, but often needs that two-way relationship, mutual friending.
And Twitter, the microblogging platform, famous for its character limit, historically 140 characters, that forces concise communication.
Right. And Twitter's interesting because the different ways information flows. The source highlights two key types.
Unidirectional and bidirectional.
Exactly. Unidirectional flow is when you follow, say, a journal or a key opinion leader, but they don't follow you back. You get their info, but it's passive consumption.
Okay, and bidirectional.
That's when you mutually follow each other. That enables real interaction, back and forth communication. That's essential for collaborative learning.
And that flow, especially the unidirectional kind, is key for getting information out fast. Journals using it.
Hugely important for rapid dissemination. With so many articles being published, especially open access ones, journals heavily rely on social media now. Many even have dedicated social media editors just to promote important studies instantly.
And they had to innovate to get around those character limits, right? The visual abstract.
It's a major innovation. It's basically a concise picture and infographics summarizing the study's main points, methods, results, conclusion. It packs a visual punch and gets around Twitter's text limitations.
Does it actually work? Is there evidence that helps?
Compelling evidence. The source cites a study in the Annals of Surgery. They compared tweets promoting an article, some just text, others with a visual abstract. The results were really stark. Including the visual abstract led to a threefold increase in article visits. 3 times. It proves that tailoring content visually for the platform drastically boosts engagement with the science.
Okay, from just getting info out, let's move to active learning. Revitalizing the journal club using social media. What were the problems with the old way?
Traditional in-person journal clubs often struggled. Poor attendance because residents were busy, inconvenient timing, maybe no local expert available to really lead a deep discussion on methods or stats.
Social media fixes the logistics.
Completely. Time and geography disappear. It allows asynchronous discussion. Someone in Asia can jump into a discussion moderated by an expert in the U.S. days later. Lots of specialty groups do this now.
Like the International General Surgery Journal Club, IGSJC, they track metrics.
They do. And the preliminary data shows that when they have these moderated Twitter discussions, you see a clear spike in Twitter activity, abstract views, and downloads of the paper being discussed. It definitely boosts the conversation and visibility.
But here comes a nuance again. Is it actually better for learning?
The critical caveat. There's that randomized trial, McLeod and colleagues, 2010. They compared a structured, faculty-moderated in-person journal club against an online discussion format.
And the in-person group did better.
Significantly better, yes. The residents in the traditional, moderated face-to-face setting scored higher on validated tests of critical appraisal skills.
Wow. So easier logistics might mean less depth in learning how to really pick apart a study.
That seems to be the trade-off, or at least a major concern. Online clubs are great for reach and access, but they might not yet replicate the focused, dynamic expert moderation needed to really hammer home those core analytical skills, evaluating methods, spotting bias. It suggests convenience might come at the cost of depth and skill development.
So if you do run an online journal club, there are tips for making it work.
Yeah, the source lists several key things. Practical stuff like setting up a dedicated web page, registering a unique hashtag, but also engagement strategies, like actively inviting the original authors or recognized experts to join the chat.
Okay. Another big use, live tweeting conferences. This lets people attend virtually.
Thousands of people, potentially. They can network, learn, share ideas without the cost and time of physical travel. It massively expands the meeting's reach. But here, we need to be clear on the metrics. Reach versus impressions.
Right. They're different. Reaches.
The number of unique people who saw the message, like unique individuals walking through the door.
And impressions.
That's the total number of times the message was delivered. If one person sees the same tweet 5 times from different people they follow, that's 5 impressions, but only 1 unit of reach. Impressions can be huge, way bigger than reach, showing how saturated the information flow can become.
And tools like the Healthcare Hashtag Project track this, showing the massive spread.
Exactly. They can see who's tweeting the most, how many mentions, and these astronomical impression numbers demonstrated that exponential spread. A few key influencers can push content out to hundreds of thousands, even millions.
Okay, finally in this section. Interactive forums and crowdsourcing, like Wikipedia, but for surgery.
Sort of, yeah.
Mm.
Crowdsourcing is just gathering input from a large group.
Mm.
The American College of Surgeons has web communities like this, based on specialty or region or interest. Members post discussion threads could be a tough case, a historical question, even policy debates.
The source mentions a specific example, the International Hernia Collaboration, IHC.
Yes, a really active Facebook-based community, but its vetted members are approved surgeons, providers, industry reps, so there's a baseline of expertise.
Then they use it for
Real-time, case-based learning. People post tricky hernia cases, ask for advice, debate controversial stuff like mesh types. It allows for rapid dissemination of new techniques or warnings. It's leveraging the wisdom of the crowd among professionals.
Before we get into the ethics, a quick note on using this for public education, patient portals, blogs.
Right. Organizations do use these tools to educate patients and families, which is great for accessibility.
But the big caution.
Accuracy. You absolutely cannot guarantee the accuracy of health information found randomly on social media or the web. Providers have a huge responsibility here. Guide your patients to reputable, peer-reviewed sites and warn them strongly against relying solely on Dr. Google for major health decisions.
Yeah.
Okay, so we've seen the power and the reach. Now we have to tackle the other side of the coin, the potential for things to go wrong. The ethical and professional pitfalls are significant. The source lays out 5 major ones.
Let's start with the pitfall 1, adoption and utilization. Basically, the tools are useless if people don't use them effectively.
Exactly, and the numbers are a bit sobering. Studies show, maybe 75% of medical students use social networking sites generally, but only about 1 in 5, just 20% uses them specifically for educational purposes.
That's low, and it impacts effectiveness, like in that journal club trial.
Precisely. Low participation in the online group was flagged as a key reason for their lower scores on the critical appraisal test. Engagement is directly linked to effectiveness.
So the fix isn't just more online content.
Probably not. It's about better instructional design. We need to build in those features Cook identified, real interactivity, practice, repetition, feedback. Make the modules engaging and easy to integrate into how people actually learn and work.
Okay, pitfall 2, accuracy and reliability. There's just so much stuff online, some of it's bound to be wrong.
It's inevitable. Multiple reports confirm inaccuracies in web-based materials. So the responsibility falls squarely on the surgeon using the information.
You have to be a critical consumer. What's the checklist?
You've got to evaluate the source who made this. Look for conflicts of interest. Could they be biased? Check the date. Is this information current? And cross-check the references. Does it hold up against established knowledge?
And for patients.
Same principle, guided by us. We must direct the public to reliable, peer-reviewed resources from professional organizations, ACS, specialty boards to ensure they're getting accurate info.
Right. Pitfall 3, patient confidentiality and privacy. This sounds like a huge ethical minefield. How do you share case details for advice without breaching privacy?
It's a massive challenge. You want the useful dialogue, the crowdsourced wisdom on a tough case, but you have an absolute legal and ethical duty to protect patient information under regulations like IP in the U.S.
So what are the safeguards?
Strict ones. You must ensure the patient cannot be identified, even accidentally, from unique case details. Getting explicit patient consent before posting anything anonymously is crucial, and all comments related to cases must remain completely professional.
There's formal guidance on this from the American College of Physicians, ACP, and the Federation of State Medical Boards, FSMB.
Yes, their 2013 position statement is key. It basically says all those traditional ethical principles, confidentiality, privacy, respect, they apply equally in online settings. No exceptions.
Maintain trust online just like offline.
Exactly. They also advise doctors to keep their professional and personal online lives strictly separate and using things like email for patient care, only within an established patient-physician relationship and always with the patient's explicit consent.
And documented in the record, presumably.
Absolutely. Every clinical communication needs to be documented.
Okay, pitfall 4, non-disclosure of conflicts of interest, COI. In journals, it's standard. On social media.
It often breaks down completely. The platforms themselves make it hard. Twitter's character limit, for instance, makes a full, nuanced disclosure difficult.
And even if the original poster discloses, it gets lost.
Often, yes. If someone retweets or comments on that original post, the disclosure might not carry over. The link between the content and the potential bias gets broken.
So the obligation is on both sides, the poster and the reader.
Yes. The surgeon posting needs to make disclosure a priority. Maybe link to a full disclosure page, use standard hashtags if they exist, And the surgeon reading needs to stay vigilant, always assessing the source for potential conflicts.
Could regulations help here? Standardized guidelines.
The source suggests that might be necessary. Maybe standardized guidelines from professional bodies or even public tools that automatically link social media posts or profiles to existing disclosure databases, like the Open Payments Database. Something to build in transparency.
Okay, last one. Pitfall 5, maintaining professionalism. The internet is forever, right?
Essentially, yes.
Yeah.
Information online gets disseminated widely and it sticks around. You can't really retract something fully once it's out there. Surgeons have to be constantly aware of that digital footprint.
And studies show breaches happen at all levels.
Unfortunately, yes. Unprofessional content has been documented among students, residents, practicing surgeons. It ranges from privacy breaches to just inappropriate or disrespectful comments that undermine the profession's dignity.
Yet there's a policy gap. Not many residency programs have formal social media policies.
It's a significant gap highlighted in the source. Few programs have comprehensive policies, leaving trainees without clear institutional guidance or stated consequences for unprofessional online behavior.
What does the ACPFS-MB statement say about this aspect of professionalism?
It reinforces the need for care. It explicitly advises physicians not to vent frustrations about patients or colleagues online that erodes trust. And within closed clinical communities, security and restricted access are paramount, and patient details must never contain identifying information, #DayFee, implications, and future directions. So putting it all together, the bottom line is that this digital shift isn't optional anymore. It's required. The Society of University Surgeons basically said it flat out. Social media is a necessary component of surgery practice.
Necessary. That's a strong word.
It reflects reality. Think about Generation Z. They grew up with this. Journals are moving online only. Textbooks are becoming interactive digital platforms with video and audio. Surgeons have to use these tools effectively, or they risk falling behind, becoming obsolete.
And the future holds even more integration, beyond what we see now.
Absolutely. Right now, video coaching is often after the fact. Future applications could be much more integrated into real-time practice.
Like preoperative crowdsourcing, getting global input before a complex case.
Exactly. Posting details of a really challenging case to a vetted international group of experts before you operate, gathering advice and planning strategies from dozens of specialists.
And intraoperative video telementoring, real-time guidance during surgery.
Yes, real-time proctoring. An expert specialist guiding a surgeon remotely during the actual procedure, maybe using augmented reality to highlight anatomy or warn about potential issues. Huge potential there.
But to really make the most of this, the research needs to get more rigorous.
Definitely. We need to move beyond just implementing tech because it's new. Future research needs to focus on 3 key things.
First,
Identify the most effective formats and components. What specific mix of video, interactivity, feedback actually speeds up skill learning?
second,
Use rigorous methodologies. We need high-quality, randomized controlled trials to truly compare these new methods against the old ones. No more studies without control groups if we want definitive answers.
and third, maybe the most important.
Shift the focus of what we measure. Stop focusing only on knowledge scores from quizzes. We need to measure the real impact. Clinical outcomes and objective surgical performance. Are complication rates going down? Are OR times improving? Are these tools genuinely making patient care better? That's the ultimate test.
So synthesizing this whole deep dive, it feels like surgical education is moving down 2 tracks at once.
Kind of parallel paths, yeah.
Yeah.
You have the structured, formal, web-based learning think score, simulation aiming to standardize knowledge and technical skills assessment.
And alongside that, you have the dynamic, fast-paced social media collaboration, online journal clubs, conference tweeting, crowdsourcing forums that breaks down geographical barriers and speeds up communication.
Right. They complement each other.
But the big takeaway seems to be this. Technology gives us incredible reach and flexibility, yes. But often, its effectiveness for core learning is statistically just similar to traditional methods.
That's a crucial point. The efficiency gain is often bigger than the learning gain itself.
And that immense power comes with equally immense responsibilities. Ethical ones, confidentiality, disclosure, professionalism. The individual surgeon has to actively manage those to keep the public's trust.
Absolutely critical. The tech doesn't remove the ethical burden, it arguably increases it.
Which leaves us with a final thought, something for you, our listeners, to chew on. If professional bodies are now saying digital learning and social media are necessary for modern surgery,
How do we ensure that core skills, like critical thinking and nuanced clinical judgment skills traditionally honed through face-to-face dialogue, questioning, immediate feedback. How do we best validate those skills in a purely virtual asynchronous world?
What new metrics do we need? How do we make sure that in chasing digital accessibility, we don't accidentally lose the depth of surgical judgment that patients rely on?
That's the big question facing the profession as it continues down this digital path.
Yeah.
Something we all need to think about.